Good evening, everyone. I am Dr. Azmy Birdi. I'm a GP menopause specialist. I'm also a menopause special skills trainer. I originally qualified and trained and worked in obstetrics and gynecology for many years. And I've been working in the field of menopause, seeing patients with menopause-related problems for over 25 years. Tonight, I'm going to speak to you about what is going on, what actually is the menopause, what are the symptoms, what could help, and in terms of helping yourself, the long-term health, in terms of weight, diet, exercise, how to protect your bones, the cardiovascular system, and how long does the menopause go on for? So we'll start with terminology, because a lot of people ask and a lot of people speak about it, and they talk about, am I through the menopause? Am I perimenopausal? So a natural menopause is when you have 12 consecutive months without a period. So it's one whole year without a period. And so it can only be timed retrospectively. The mean age of this is about 51 years. Premature ovarian insufficiency, or premature menopause as it used to be called, is when you have a menopause earlier than 40 years of age. It's called premature because from 40 to 45, if you have menopause, it's considered an early menopause, but not really premature, because the ovarian activity and the aging of the ovary starts commencing in the 40s, and from 45 years plus, there is a stage of transition where the ovary is gradually slowing in terms of its function of producing estrogen. But if somebody has a cessation of periods and they are truly menopausal before the age of 40, this is premature. It has great implications for their health, their bone health, their cardiovascular health, their brain health, and therefore it's considered to have occurred prematurely. It's called ovarian insufficiency, and they don't really call it as ovarian failure or definitely menopause, because in this age group, sometimes these younger women will have periods where the ovarian activity may just come back for either months or years, and then the ovaries peter out again. So it's considered to be ovarian insufficiency. They can sometimes conceive. In fact, 5 to 10% of them can conceive spontaneously. But an early menopause is when they have had the onset of menopause between the age of 40 to 45 years. From 45 years onwards, the ovaries are going into a stage of transition. So although I started off by saying that natural menopause consists of 12 consecutive months without a period, very few women will experience their periods just stopping abruptly at the age of 50 or 51 and not seeing any bleeding after that. In most women, there is a transition phase where they get hot flushes, they get night sweats, they have some period irregularity, and these signal that the menopause is approaching, and it is called the menopause transition. So why has this become so important recently? Why is everyone talking about it? Why didn't we talk about it in the years gone by? And lots of people will say this is a new construct. This is something that's new. This is newfangled. In the old days, nothing bothered women. They were able to get on with it. And this is something that has been a product of the 21st century. But the reason for this is that in 1850, in the olden days when people didn't talk about the menopause, it's because in 1850, the age of menopause was 45 years. In 1900, it was about 50 years. The life expectancy in the 1800s was only till the age of 45. So women did not live much longer after the menopause. But now we see a changing population. You know, the number of people over 75, over 85 have increased. Just women over the age of 45. So these are women in the transition phase of life. So they're either approaching menopause or have already experienced it. They constitute 20% of the population. That's 1 in 5, really. And the female life expectancy in the UK today is 86 years. If they have if they experience menopause at the age of 50 or 51, then that is about 35 years that they will live in a state of menopause. The menopause doesn't end. You live with the menopause. You live in that phase of life, like you have pregnancy, you have puberty, you have adolescence, you have the teenagers. These are the menopausal years. When people say they're through the menopause, what they mean is that they have probably stopped having the hot flushes and night sweats and the symptoms they experienced in the early stages after their period stopped, or just around the time when their periods were slowing down. But they will be living in a postmenopausal stage of their lives, and that is why health and well-being at this time is so important. So there's a midlife dip in well-being that's been seen in various studies, and you can see that the drop occurs. There's the lowest trough, and then it starts to rise again. So what happens is that from the 20s and the 30s, and when you're in the full bloom of youth, to the 40s and 50s, people do experience a decrease in their subjective sense of well-being. But particularly if they look after themselves well and they don't have other medical conditions, usually after having reached that lowest point where you realize, or your body's never going to be the same as it was in the 20s and 30s, actually that sense of well-being starts to improve. And this is if you can look after yourself well with diet, exercise, and other ways to have a happy social life and feel fulfilled. So an unfortunate history of the menopause was that few women experienced it in the olden days, just because they didn't live long enough. But those that did live longer, and those that had an earlier menopause, they were treated in a way that we cannot imagine now. Women were defined anyway as deformed males, and the menopause was considered a stage where they actually became more like the male ideal. But then women being women were considered not able to cope with this male ideal, and then for them it becomes like a disease. That was the thinking. So they were made to do all sorts of strange things, like sitting in hot rooms to sweat more, putting cold water to the abdomen, leeches on the genitalia and the cervix, and subjected to all sorts of things. And this is actually a list of conditions for which people could be admitted to what they used to call lunatic asylums or insane asylums. We don't have asylums anymore, even though people still are admitted to mental health facilities. But if you can see, what's been underlined is imaginary female trouble, hysteria, menstrual derangement, suppression of menses, which is basically menopause, women trouble, female disease. So women were sent off and locked away if they were experiencing symptoms or behaving, displaying behavior, psychological symptoms that were not in keeping with how society thought that they should behave at the time. And that's another reason why it wasn't a big problem in days gone by. They were just locked out of sight. So what happens to your body? What happens to our bodies at the time of menopause? So it's about ovaries and it's about estrogen. So as you can see from the graph, you will see the stage of pregnancy where the hormones reach their peak. That's in the full reproductive stage of life. You can see that they're normal cycles. The sine waves that you see up and down are the hormones going up. And then if there's no pregnancy, then it's followed by a period. And this occurs regularly. But this changes. This changes after the menopause, and these hormones do not occur cyclically, and therefore ovaries do not produce estrogen regularly, and that affects the body in different ways, as I will explain soon. So, laboring the point again, as you can see, before the menopause, the premenopause, which is the reproductive stage in life, and it's considered to be 15 to 45 years of age. That's not to say that people cannot conceive before the age of 15 or after the age of 45, but these are the main reproductive years. So there is a regular rise in hormones, then you see a peak, and then there is a fall in hormones, and if there's no pregnancy, then you get a period. But if you can see, there's a stage of transition, and that varies. It can vary from the mid-40s to somewhere in the early 50s, and you get fluctuating hormones, and therefore you can see how erratic the cycle can become, and this is because the hormones are completely erratic. Eventually, whether it's in the early 50s or it's later on, but some usually in the sixth decade, that's between 50 to 60 years of age, the hormones will gradually decline to an all-time low and periods will stop. When they will stop depends a lot on when a woman's mother had her menopause. So the best way to find out, to predict your own menopause or what age you'll have your menopause is ask your mother. And people do follow their maternal patterns, especially if their mother had an early menopause and for a late menopause as well. So some women do menstruate even at 56 or so, 57, 58 is known to be a late menopause. But usually by 54 to 55 years of age, most women would have had at least 1 year with no periods. That is the norm. So, will a blood test tell me if I'm menopausal? Lots of people ask that, and this is why it will not. Blood tests are not helpful. Can you see what's happening? This is how hormones are fluctuating, and the estrogen and progesterone, which are secreted by the ovaries, and they form the normal menstrual cycle. They fluctuate widely, even within the course of the same day. So hormones are not helpful. Even NICE, which is the National Institute of Health and Care Excellence, says there's no point checking blood tests to diagnose menopause if the woman is 45 years plus. But if they are more than 45 and they've got strange symptoms that are not typical of menopause, if they are experiencing things that make you suspect there may be a medical problem, then blood tests may be done. Sometimes we do blood tests for women who have had a hysterectomy at an early age, in their, say, 30s, and then they reach their 40s. They've still had their ovaries inside. There's no way to tell if they are menopausal except by taking a blood test. But even in those women, the hormones fluctuate a lot, so it's very, very difficult to tell. Blood tests are generally for younger women where you're suspecting premature ovarian insufficiency or premature menopause under the age of 40, and then blood tests are done. So what are the symptoms of menopause? So as you can see, there are various apps and there are various websites, and they talk about 34 symptoms, and they talk about there's certain websites and applications that will list even more symptoms. But the main ones, generally speaking, are cycle changes. So the cycles become shorter or longer, you start missing periods. Hot flushes are extremely common, tiredness and poor sleep, There is loss of sex drive, partly because of the hot flushes, maybe tiredness, poor sleep if there are other symptoms. Sometimes it's just because the postmenopausal ovary is slowing down and the hormonal dip is causing a lack of libido. Women report anxiety very commonly. They report brain fog, where they actually lose focus, there's word finding problems, and then 50% of women will also report at some point in time dryness in the vagina and difficulty with sexual intercourse because of that dryness, causing pain and discomfort. So it affects going into your period stopping and going into the next stage, the later stage of life, the post-reproductive, the post-menopausal stage of life, have implications both for the external appearance as well as for bodily systems. So this is an American slide, so it talks about hot flashes. Well, we say flushes here in the UK, but it's basically the same. A lot of women start complaining of headaches and migraines, particularly if their periods are getting erratic, and that's because of the hormonal fluctuations. Hair and skin changes. The gums start receding, and that creates problems for the teeth. Bones start losing mass and become fragile. So the estrogen keeps the bones healthy. There's a balance between bone build-up and breakdown, and the bones are very rich in estrogen receptors. And once the estrogen wanes at menopause, bones do get thinner. They become more fragile, and women are more prone to have thinner, softer bones than men, and they are more likely to get osteoporosis. And that's another reason for problems, dental problems, because the teeth get looser if the quality of the bone in the jaw is affected. It's a well-known fact that men have more heart problems, especially heart attacks, more than women up to the age of about 50, 52, and then women start catching up. And that's because the estrogen keeps the blood vessels into the heart all flowing and open. It has an effect of dilating the blood vessels, stretching them open, keeping them nice and flexible and pliable. But that changes after menopause. People often complain of backaches because their ligaments and their muscles also have estrogen receptors and are affected. They complain of aches and pains and joint pains often. The skin can get quite dry and itchy. Women start putting on weight around their abdomen, which is unusual because women have a pear shape with most of the weight around the buttocks and the hips. But once their periods stop, they tend to become more apples, and they start to have a fat deposition on their belly. The vagina gets dry, and it can be itchy. It actually can shrink, particularly because some women stop having sex at this point in time, and then if it goes on for a long time, it can shrink, and the nice supple elastic tissue in the vagina gets replaced by scar tissue, fibrous tissue, and it can become very, very difficult as time goes on. So often the first signs that the transition has started, the perimenopause has started, are shorter cycles, irregular cycles, or both. And 1/3 of patient visits to a gynecologist are for abnormal bleeding. That is all visits to a gynecologist, 1/3 of those will be for abnormal bleeding. But if you look at women who are in the transition phase, the perimenopausal and postmenopausal, in that group, about 70% of gynae consultations, 70% of these women will see a gynecologist. If they see a gynecologist, they'll be seeing them for problems with bleeding. So in terms of symptoms, I talked about hot flushes and night sweats. I talked about the lack of libido and the headaches, the palpitations, and joint pains. Often women feel very depressed, partly because if they're experiencing other symptoms, it can affect their psychological well-being if they're not sleeping properly, for example. But also women can report anxiety and depression, which arise during the menopause, and it's hormonal in nature. It's also the time of peak migraine prevalence, the perimenopause, when they're actually bleeding all over the place. And a quarter to a third of women who attend menopause clinics have migraines. And those that do have menopausal migraines, or perimenopausal migraines rather, will say that they're having a severe attack at least once a month, if not more. So it's quite debilitating. It does affect their functioning. There's been a lot about menopause in the workplace now, and menopause forces 1 million women to retire early. This was from the Times at the end of last year. And it said that 1 in 5 women are leaving work. And nowadays, we've got a lot of women between 45 and 55 in employment. The cost of living is rising. We're not getting the same pensions as people did in the previous years. You have to stay working in order to get money. And of the women who were working and they were approaching menopause, the perimenopause or postmenopausal, 60%, 6 out of 10 said that actually significant impact on my work. This is really affecting my work. And this is borne out for me in practice, because I see lots of women who are coming in floods of tears. They don't want to stop work, but they're almost stopping work because they're terrified that they'll make a mistake, and it's very hard for them to carry on working when they're feeling so unhappy and unwell and symptomatic in their own bodies. So what is a healthy menopause? Yes, you lose ovarian function, but a healthy menopause is actually a dynamic state. Yes, you've permanently lost ovarian function. That's not coming back. But it really is, it's what's perceived by a individual woman, that she is in a state where her physical, psychological, social functioning is actually satisfactory. Now, all of us have an image of ourselves, so you have to, within the limits of what is realistic, and not allowing for that's unrealistic. We all have a desire to adapt, a capacity to self-manage, and that the whole idea of having a healthy menopause is to be able to adapt to the later stage of life and to be able to incorporate disease and disability. And that's not to say that this is inevitable, but problems like blood pressure that come up, problems like joint problems that come up, the slowing down that comes up, it's got to incorporate that. It's got to incorporate the changes that will come with age, but then enable you to live a happy and healthy life. So, coming to the hot flushes and night sweats, these have really got a lot of implications just beyond the fact that you sweat and you feel warm. They have problems for women in terms of affecting their sleep, because what normally happens is that body temperature falls in the evening, and the lower the temperature, the better able the body, the better the woman is able to fall asleep and stay asleep. Sleep is always better when you are cooler. And then body temperature rises in the morning in preparation for wakefulness. And these temperature changes are subtle, so they cannot be picked up via measuring your temperature with a usual thermometer that you buy over the counter. You need a basal body temperature thermometer, which is found in lab conditions. So if somebody is having a hot flush at 10:30 at night, that is going to destroy their sleep pattern. And flushes do not go away overnight. They can last on an average for 7 years, sometimes even more. So they can come and go, but they can last for quite a long time. And it varies from person to person. So they have implications for sleep, And sleep is very, very important. I mean, the quotation from Macbeth that sleep puts each day to rest and it heals hurt minds and it's the most nourishing, that is actually true, because good quality sleep is important for health, for performance, for quality of life. And as you get older, regardless of gender, sleep problems do tend to rise. But women are more susceptible to having problems with sleep than men do. And in midlife, from the age of 45 plus, there has an increased risk of having other medical problems, high blood pressure, blood sugar, diabetes, as well as mood problems, stresses and strains of day-to-day life and families. This has an effect on sleep as well. Sometimes medications have their effect. People have been given medications for various reasons, and that can impact on sleep. Weight changes at midlife. Sleep. So overweight people generally tend to have poorer sleep, and that is because sometimes they have to wake up in the night to pass urine. That is linked to weight as well. And then some of them may have other comorbidities, other conditions. So sleep in itself is not an isolated and independent condition. Insomnia is not. They are always factors. Stress not least of all. If you're working on your laptop or there's a lot of screen time, we're constantly doing things till late in the evening, that affects the melatonin in the brain that regulates the sleep-wake cycle. It causes problems. The sleep is very important for cardiovascular health as well as it really does impact on every organ system of the body. If you're not well rested, then you're not going to be functioning mentally well either the next day. So how do you manage hot flushes? Because this is what most women up to complain really bothers them. So they are non-medication options. They are, that is, regular low intensity exercise, not too late in the evening, otherwise you raise your body temperature and you're not able to sleep well. But something like yoga, to use layers of clothing so that they can take them off, put them on again. Weight loss helps. A lot of the heaviest women have the worst hot flushes and night sweats. Try and sleep in a cooler room, turning down the central heating in the bedroom. Use a fan, especially a fan that's directed towards your head and face and the neck, because this is the bit that gets very warm, particularly in the night. So a table fan on the bedside table is fine. Reduce stress. It's easier said than done. And then there are things called chillo pillows or chill pillows, and they're gel mattresses that people can use, and they have a cooling gel incorporated, which will help to keep the body cool and help people to sleep. And then avoid triggers like spicy food and alcohol. They generally tend to be associated with worsening hot flushes. And then there's medication that can be taken. And there is HRT, which is hormone replacement therapy. That works extremely well for hot flushes and night sweats, and it really does improve the quality of sleep. The sleep has been disturbed by sweating at night or getting flushes. And there's some women who cannot take HRT, say women who are on breast cancer treatment, they're on hormone blockers, and the SSRIs and SNRIs are groups of medication which are antidepressants. The best known of those is Prozac. And they have an effect on hot flushes and night sweats via the serotonin pathway and the norepinephrine pathway. So they can be used as well. They don't work quite as well as the HRT does. And then there are other alternative therapies. There is little evidence that they are very good, but they consist of St. John's wort, the plant estrogens, that's the isoflavones, like red clover, black cohosh, evening primrose oil. They have variable effects. So some women find them effective, others don't. There isn't very strong evidence that they do actually make a huge difference. So when I talk about HRT, women always worry about the breast cancer risk. So I address that first. So you have to put it into perspective. This slide is from Cancer Research UK. So if you look at the top slide, the line, the incidence of breast cancer is that whatever happens, whatever you do, 23 women out of every 1,000 in the UK will be diagnosed with breast cancer over the next 5 years. Okay. Now, if they took HRT, second line, second row, then you would see 4 extra cases per 1,000 women over 5 years. So an individual woman's extra risk would be 4 divided by 1,000 spread over 5 years. That's 0.004. What they did find in the big studies that reported risks of breast cancer was that in women who'd had a hysterectomy, and that's the third line down, they did not need 2 hormones. They did not need the estrogen and progesterone, because that is only needed for women who have got a womb. And you saw from the earlier slides that the estrogen and progesterone regulate the lining of the womb, then it breaks down and it sheds. So if you've had a hysterectomy and you choose to go on HRT, it's usually estrogen only. So actually they found that there were 4 fewer cases. The green women, the green figures are the cases, the number by which it decreases. So estrogen only didn't actually affect it. It was only the addition of progesterone. If you look at women who are drinking alcohol, 2 or more units of alcohol per day, there's 5 extra cases. So the more than that of HRT. And then if you look at women who are overweight or obese, that's their body mass index is more than 30, you can see it increases far, far more than if they were taking HRT. And then if women actually participate in some sort of physical activity, exercise on a regular basis, 2.5 hours per week, moderate exercise is just 2.5 hours of walking per week, that it comes to about 20 to 25 minutes per day, they actually reduce their risk. So it's got to be seen in perspective. So the general outcomes with HRT is not suitable for everyone, sometimes because of medical reasons, sometimes because of personal choice. But for those who wish to consider HRT, and there is no reason for them medically not to take it, it's worth knowing that actually those who do take HRT, women who do take HRT, live longer and healthier lives than those who do not. That's been shown in a lot of studies. And if you are heavier, you have a sedentary lifestyle with no exercise or movement, high alcohol intake, blood pressure not being controlled, it causes a much greater impact, has a much greater risk of having mortality, dying of it, causing other disease conditions in postmenopausal women, even when you directly compare that with HRT. Now, as I said earlier, sometimes menopausal symptoms can last, and usually they do, for much longer than they previously held belief that it was just 2 to 3 years. So half of women will experience symptoms for 7 years, and 42% of women in their 60s, between 60 and 65, are still experiencing symptoms, and a small percentage, about 5 to 10%, will have lifelong symptoms. It's very difficult to know which category you're going to fall into. So what are the benefits of HRT? So vasomotor means hot flushes and night sweats, so it gives excellent relief of vasomotor symptoms. It helps psychological symptoms as well. It protects bone, so it prevents osteoporosis, and it reduces fractures. It reduces heart disease. I've put in brackets timing, and Alzheimer's disease also timing, because the current thinking is that there is a window of opportunity when a woman goes through the menopause, and that's in the early stages, either within 5 years of the menopause or certainly before the age of 60, when the effects of estrogen depletion on the blood vessels in the brain and the heart are not quite so severe. And if HRT is instituted at that time, it keeps the heart muscles and the heart vessels strong, supple, pliable, open. less likely to get blocked or hard, and a similar effect in the brain, and therefore there is a benefit in terms of reduction of heart problems like heart attacks, myocardial infarct, and also seems to help with Alzheimer's disease. That doesn't happen when women start taking HRT for the first time over the age of 60. And the reason for that is the way the tissues will respond to estrogen close to the menopause is different from how they will respond later on when those tissues have already changed and become less hormone receptive. So that they are more likely to be receptive to the effects of HRT closer to the time of menopause than when they are exposed to HRT later on in the menopause. Certainly from the age of 60 onwards, the benefits start waning, and from 70 onwards, there's more risk than benefit in initiating HRT for the first time. But women who do take it and take it in a timely manner find that actually there is a 30% reduction in risk of diabetes. And they have also found during this pandemic that women who were taking HRT had protection from COVID-19. Now, this did not mean that they would not contract COVID-19. It meant that these women were actually less likely to get the complications of COVID-19, but less likely to be intubated, less likely to have severe disease. And that came out very clearly from the early studies in China and the Hubei province, when they found that women who had higher levels of estrogen did better. The study was repeated in Oxford, and they found that women who were on HRT certainly had reduced mortality from COVID-19, and they were less likely to be intubated and go on to ICU and have complications. So HRT is ideally, if you are going to start, it's ideally started around the time of the transition. Nowadays, there's the belief, and more and more evidence is emerging, that hot flushes and night sweats, the vasomotor symptoms as they are called, are actually biomarkers of cardiovascular risk in diabetes. So the higher the number of hot flushes and night sweats, the more the woman is plagued, the more likely these women are to be having heart problems and diabetes, and that's why giving HRT, if they are eligible, actually does seem to confer some sort of benefit. But the management plan has to be acceptable to a woman, and if some women just don't like the idea of taking it, or they're frightened of taking it, or the HRT doesn't suit them, then it is not worthwhile. And you've got to remember, menopause is not a single disease-focused model. People have many different symptoms of menopause. Even within the same family, people respond differently to treatment. So it has to be personalized, has to be individualized for each woman. And it's very important to distinguish between what are the natural effects of aging. You know, these hair getting a bit thinner, weight going up. These are the natural effects of aging. And what are the effects of declining estrogen eventual deficiency? I mean, hot flushes and night sweats are very classic. That is very strongly linked to estrogen, and replacement with HRT does help. But it's less likely to be of benefit sometimes for things like weight. For that, you do need to drastically alter your eating pattern and exercise. And then the important thing is is there any illness, is there any medication that a woman might be taking that is causing symptoms, and she might be thinking that just because she's 50 or in her 50s that it could be because of menopause. Now, the NICE guidance has said that for psychological symptoms, if there is low mood and anxiety or depression that arises as a result of the menopause, especially if it comes for the first time during the menopause, then they've said that it's worth considering HRT, because in the past, a lot of these women were given the SSRIs, SNRIs, as I explained. Those are the antidepressants like Prozac or sertraline to ease low mood, to ease anxiety in the menopause. and they actually did not have clinical depression. It was also that the cause for the symptoms, for the psychological mental health symptoms, was hormonal and not depression. So it's important to treat it accordingly. So what are the types of HRT? Very simple. So if you had, as I explained to you, that it's the estrogen and progesterone, two hormones that regulate the menstrual cycle and the lining of the womb. So if there's been a hysterectomy, if somebody has had a hysterectomy, no uterus, then it's estrogen only, otherwise they need both the hormones. And what are the different preparations you can get? So there's oral, there's tablets, there is transdermal or HRT given via the skin, estrogen given via the skin. There can be a patch or a gel or a spray. If the woman just has, you just have vaginal symptoms and it's just dryness but no hot flushes, night sweats, or there's somebody in their 70s that just has the vaginal dryness, it can be given vaginally. And it's very important to understand that nowadays we have regulated body identical HRT, which is basically the precise duplicate of what your ovaries would have produced of human hormones, but they've been developed conventionally, they've been developed in labs and they've been marketed. These are authorized by the regulators of the pharmaceutical industry. And the advantage of giving it via skin, and a lot of more and more women are having the gels and the patches, is that you avoid the medication going into the stomach, being broken down into the liver. It's more physiological in the sense that it's more like how your ovaries would release it directly into the bloodstream. It's absorbed through the skin. If the patches are too much or the dose seems excessive, they can be cut in half, they can be cut in quarter. It's very good for people with bowel problems, and it's better for people with lactose sensitivity, for blood pressure problems, if they're taking blood pressure medication, if they're using other medication. And if taking it via tablet form does increase your risk of clotting slightly, not as much as the pill causes thrombosis, but it does a bit because it goes into the liver and it's broken down and it increases clotting factors. So it would have to be stopped if you had surgery, for example. But giving it through the skin does not affect your baseline risk of thrombosis. So NICE guidance again says that women with significant cardiovascular risk should have HRT. They can have HRT, but they can have it via patch form or gel form, and it does not increase the risk of thrombosis. So you have a lot of flexibility with dosing. Contraception is important. If you have menopause before the age of 50, then you still need contraception for 2 years. If it's 50 plus, then it's 1 year. Nowadays, you have newer types of HRT, as I said, the body identical type of HRT, biologically identical with what your own body produces, and they are found to be safer and in terms more breast friendly in terms of breast cancer risk. So you get something called utrogestrone now, which is oral micronized natural progesterone. And just remember, we talked about bleeding problems earlier and saying that I said that women have a lot of bleeding problems around that time. A lot of women have bleeding problems at that time. And the Mirena coil is actually licensed by HRT. The license is for 4 years, but all the authorities say that it can be used for 5 years, and it's very, very useful. The other problems that can occur are, and these problems occur later on rather than immediately, more likely to occur a few years or several years after the menopause, where the vaginal lining, which is thick and moist, and the vaginal walls, which are flexible, the vagina becomes dry, the lining becomes thin, there's less blood flow to the vaginal tissue, the flexibility decreases, and the vagina can shorten over a period of time. So women report itching and burning and painful sex, and they feel like passing urine all the time. So this is something that comes up a bit later, and this gets worse over time usually. Hot flushes and night sweats start early and get better. This starts later, it tends to get worse. So it's important that you look after your vagina. We look after our face. We put hand cream if you're washing your hands all the time. You put night cream and day cream and sun cream. But it is important that the vagina gets some moisturization as well. So there are various things that can be used for moisturizing. There's Replens, there's Yes, which is VM is vaginal moisturizer. There's Silk, something called Regel, and it can be used every 2 to 3 days. And it's important to lubricate the outside, the skin of the vulva as well, because that can get dry or itchy too. It's very important to distinguish between what is a moisturizer and what is a lubricant. A lubricant is only meant to reduce friction during intimacy, whereas a moisturizer is actually to keep that tissue healthy, to plump it up a little bit. And it's best to avoid KY jelly. It's not considered very good nowadays when there are better options on offer. And then sometimes it's just because the estrogen is depleted so much, you need to replace that estrogen, otherwise she's not going to improve. And the topical estrogen means it's estrogen given just inside the vagina. And it improves tissue moisture, it improves the elasticity, it reduces the burning and the itching. It helps to make sex more comfortable because there are estrogen receptors around the urethra where the urine comes out. Helps to reduce recurrent urinary infections in some women. And the important point to remember here is that this is different from conventional HRT. This is different from the patches and tablets and other things that people use, because this is minimally absorbed. There's virtually no absorption inside the body, so it can be used very safely. Sometimes in some breast cancer patients, if they're on tamoxifen, they can use it. They can't use it with some other hormone blockers, but they can use it with this. And it is nothing to feel frightened about. It does take about 12 weeks for the full estrogen effect to take place in the vagina, and then you need to carry on with the treatment for about 2 to 3 times a week on an indefinite basis. If you stop taking it, stop using it, and then restart, then it is going to you're going to go back to square one, then having to start again. So it's important to remember that. And then mood. Lots of people say that they have mood swings, they cry, they don't know what's happening to them, they don't know why they're crying. And memory issues, mood, anxiety, irritability, well-established association with the menopause. And it's because the estrogen receptors in the brain, in the amygdala, which is the very old primitive part of the brain, it's right at the bottom. You can see that tiny little thing, the tiny little knob, and it is programmed to respond to fear, to aggression, to anxiety. So you have the fight or flight response. And while there's estrogen receptors in the brain, what happens is the amygdala doesn't have many estrogen receptors. The hypothalamus and the thalamus, so the hippocampus particularly, which is responsible for memory and learning, and that is very rich in estrogen receptors. When the estrogen is withdrawn at menopause, what happens is that it is not able to put the brakes on. It is not able to put the control on the amygdala, which, being a very old primitive part of the human brain, keeps responding to every little thing with fight or flight, with fear, with anxiety, with anger. And that's what a lot of women say, they can't control their temper. And that's what happens. So, people say, if I don't take HRT, is that it? Am I doomed? So there's no doubt HRT improves memory in the short term as well as in the long term. It lifts that brain fog, it improves mood, reduced anxiety, reduced irritability. But sometimes there may be underlying depression for various reasons. So, doctors will explore various options with patients, including antidepressants, anti-anxiety medications, and other things that help, like breathing exercises, mindfulness, CBT. All these are very, very important things as well to consider, rather than just HRT alone. Women report low libido, so it's important, and that again is multifactorial. So what is the relationship like? Is it that they're getting so many hot flushes and night sweats that they are so physically miserable that they are not able to engage in a relationship because they're feeling unwell? Is it because the vagina is not moist enough? Do they need lubricants for intimacy? Everyone needs some lubricant for intimacy. You may not have needed it in your 20s, but you certainly need it in later life. And then there's a synthetic HRT called Tipolone, which is a tablet which helps the hot flushes, it helps the night sweats, it helps bone, but it also has a slight effect in terms of testosterone-like effect, and which is the male hormone that drives libido. Everyone's talking about testosterone nowadays, and testosterone gels and patches can be very effective for low libido. Usually there needs to be a blood, it's not mandatory, but it's good practice to do a blood test before starting, just so you know where the baseline level is. If you're doing a blood test for testosterone, it should be 9 o'clock in the morning, because that's when it's at its steady state. Otherwise it tends to go down over the course of the day. And it has to be used very carefully, because otherwise you can get symptoms like acne and hair growth and more anger and more aggression. And obviously if there are relationship problems, then those have to be addressed in order to achieve, a satisfactory sexual life. And then there's the sleep problems. A lot of people sort of say, well, what can I do about the sleep? So improving hot flushes sometimes automatically improves sleep. But if you've not been a good sleeper before the menopause, then it becomes harder to treat. And there are many people who have had long-term problems with sleeping. They've never been good sleepers. The overwhelming evidence is actually for looking at things like the Sleepio app, which is cognitive behavioral therapy for insomnia, and these work better than any medications. Good sleep hygiene, getting into proper sleep routine, stress and anxiety management. So it has to be tackled in different ways depending on what else is going on. But sleep is very important for memory and for cardiovascular health. I'm going to talk about bioidentical HRT briefly because it's very popular in the private sector. They take your blood and say they're making up something bespoke for you depending on your blood test and what your levels are. I explained to you that blood tests do not have any rationale and they do not correlate to symptoms. You can have normal hormones and severe hot flushes and night sweats, and you have women who have very low levels and they have never experienced a night sweat or hot flush. And they are made up by compounding pharmacies. So basically they add a bit of this and add a bit of that depending on the blood test result, and then they give it to the woman. They are not manufacturing facilities. They're not like Johnson & Johnson or GlaxoSmithKline, who are subject to regulation. And beware of buying these things on the internet. So all the menopause societies and the pharmaceutical advisors have said that there's no evidence that they're safe. There's lack of rigorous safety measures, purity measures. You don't know what you're getting. And then testosterone again, it's mainly used. The main reason to use it would be to improve libido, but it has been used a lot for women who've had their ovaries removed. And the reason for that is that half the testosterone that is circulating in women's bodies comes from the ovaries. If you take the ovary away, automatically there will be a drop in testosterone. And sometimes some women will have persistent symptoms while they're on HRT. So the hot flushes and night sweats will go, but lots of other things stay, and they won't feel better until they receive a bit of testosterone. Usually we see these in women who've had their ovaries out, rarely in other patients. But there has been a lot of publicity about the use of testosterone in menopause hormone replacement therapy. And I'm going to end by saying that life after menopause is not all doom and gloom. The end of your fertility, the end of of your younger days and the start of midlife doesn't mean that it's a start of decline. Actually, the term climacteric, which is used for menopause in certain medical textbooks, means ladder. It comes from the word, a Greek word, a Latin word, ladder. So I think it's a state of elevation. So you entering your decade of power now, where hopefully you've discharged your duties as a mother. The children are more independent. You've got something to do. You've got some time to do things for yourself. And then lastly, I'm going to end with a plea that it's cause for menopause. So this is a book I wrote during the pandemic. It is about the life of Pesi Barucha, who was a surgeon. He was also my father. He led the smallpox eradication campaign in India for WHO during the epidemic in the 1970s, and he was responsible for eradicating smallpox. And it's available on Amazon. It's only $3.75 as for paperback, and even I think it's just less than £1 for the Kindle. If you're on Kindle Unlimited, you get it for nothing. And any little profit that I make, which is none at the moment, but if I did, anything I get from there goes into menopause education and menopause services. So if you'd like to buy a copy, or if you'd like to give it as a gift, please may I request you to do so. And I am ending with giving you some resources that you can refer to and saying thank you for having me. I'm sorry I couldn't be here in person.